Welcome everyone to WellMed Charitable Foundation's Caregiver Teleconnection series. This one is Engaging Care, a program for healthcare workers, a series by Dr. Elliot Montgomery SKlar and Lucy Barylak, who's a master's in social work. Let me tell you a little bit about these experts that we have today. Dr. Elliot Montgomery SKlar is a public health professional focused upon supporting the health of the public through academic work, research, and service. He has had healthy aging programs for seniors and for caregivers in Canada, Florida, and on the web. Dr. SKlar is an associate professor of healthcare sciences at Nova Southeastern University in Florida. He publishes and presents his work internationally, which is focused on the complexity of issues related to aging and caregiving. Lucy Barylak has a master's degree in social work from McGill University. She is presently working as a consultant for a health network in Montreal, Canada. She's been involved in various research projects and has published numerous articles related to caregiving issues. She has lectured at several universities and colleges on innovative approaches to caregiving, and she presents annually at international and national conferences. Lucy is also a consultant for private industry in the United States, like us, including her work with the WellMed Charitable Foundation and clinics in Texas. In addition, on a personal note, Lucy would like you to know that she was a caregiver for her mother for about 10 years. And with that, Elliot, Lucy, welcome.
Thank you so much, and a huge welcome to those joining us today. We have a very exciting program. It is our last in our series for healthcare workers. And today we're going to be talking about gender diversity and caregiving. We have learning objectives for our program today to discuss the role of diversity in healthcare. We're also going to talk a bit about cultural competence, which may be a new term for some of our participants. We're also going to be talking about caregiver experiences based upon gender and sexuality, and we'll identify strategies for supporting diverse patients and caregivers, as well as cultural competence in long-term care settings and why it's important. If you would like a certificate of attendance, you can email your contact information to caregiverteleconnection@wellmed.net. And as always, we do provide a copy of our slides from today. So, let us begin by first talking a bit about what culture is. It might seem obvious to some of us, but I think it's important for us to define. And culture is really the symbols, the language, the norms, values, and artifacts within an environment. It could be anything really, a community. Language also makes effective social interaction possible, and it helps to influence how people conceive of these concepts and objects. I think also most importantly, culture is influenced heavily by our upbringing. And I love the saying that we don't see things as they are, we see them as we are, because I really do believe that to be true. And unfortunately, there is a culture of care in our society. Caregiving is sometimes thought of as a gendered, feminine act, which it is not, and we're going to talk more about that today. It's interesting if you look at the statistics on caregivers from the AARP's Caregiving in the US 2020 report. I wish that they had newer data out in light of COVID, but they only release this study once every 5 years. So we're halfway through, but I think that the data will have changed quite a bit because of our experience of COVID as well. And I think it's also important that even though this is national data that we see, this may be different in different parts of the country and different communities. There are certainly higher concentrations of diverse caregivers in certain large cities and certain rural areas, for example. So we do know that about 40% of caregivers are culturally diverse. About 17% report being Hispanic or Latino. 14% report being non-Hispanic, African American, or Black. 5% report being Asian American or Pacific Islander, and 3% indicate that they're multiracial. But we know there's a lot of underreporting, and certainly within some communities and cultures, the identification of oneself as a caregiver is different because in some cultures, we simply believe that that is our responsibility. What I thought was very interesting is that about 11% of full-time caregivers are students enrolled in college. So these are people I work with on a daily basis, and certainly have unique demands placed upon them in terms of deadlines for schoolwork, other full-time work, and the responsibility of caregiving. About 9% are active duty in the US Armed Forces, and about 8% self-identify as part of the LGBTQ plus community, which we'll talk a bit more about as well. What I always find very interesting, and I encourage people to do this as well, and I actually did look this up just a few days ago, nothing changes if nothing changes. Just as our population is becoming more diverse, we know that seniors and caregivers are as well. But if you Google the term family caregiver, and if you search under the images tab, and I would encourage people to do this, take pause and think about the images that you see, because what you'll find is that most caregivers are depicted as women. Most healthcare workers supporting seniors and caregivers are depicted as women of color. Now, the common depictions of caregivers and outreach efforts to caregiving populations has not yet caught up with the reality of caregiving in America. And when it comes to medical care, studies have actually found that African American and Hispanic caregivers report feeling invisible in some medical facilities. Mm-hmm. Caregivers know their partner's medical history, their symptoms, and their needs. But when there are communication or cultural breakdowns with providers, that can result in a poor response or dismissal of the caregiver's input, and consequently, patients suffer. So for those who work professionally with caregivers, cultural sensitivity is incredibly important, and we'll be talking about this all through our program today. Trainings like this one, we believe, are helpful to reduce presumptions and misconceptions about other people's experiences, and also to ensure the best results for caregivers and care partners. Caregivers, as we have seen, are diverse, and they should be included in a diverse manner as well. So it is important, I think, to find things that you might have in common if you're a healthcare worker. For example, if you smell something in the home that someone is cooking, ask about it, or try to educate yourself about some local culturally diverse resources. These exist in every community. You can call 211, you can look on Google, but it is very important because you want to help refer people to supports within their community, and ask caregivers to educate you about their culture and tradition. This is a great way to show that you have interest and appreciation for their culture as well.
Good morning, everybody. Welcome. That was very, very interesting. So let's ask the question: does the gender of a caregiver matter? Do you think it matters? Let's see if anybody wants to respond to that.
Okay, so *6 if you're on the phone. If you're on Zoom, you can just open up your, okay, we've got Angela wants to talk to us.
I don't think it matters.
You don't think it matters? Okay.
No, not only in the context of respecting the culture of the person you're caring for and their dignity, in that most seniors would rather a similar gender to themselves than to just have someone that is not of the same gender. Where with a guy, it can be anyone, but with women, they want a female to do personal care. So in that regard, yes, but in generalization, no, it shouldn't really matter, except at those times.
Thank you for that. Well, we know that within our complex system of long-term care, women's caregiving is essential in providing a backbone of support. So in fact, the value of the informal care that women provide ranges from 148 billion to 188 billion annually. Women provide the majority of informal care to spouses, parents, parents-in-law, friends, and neighbors, and they play many roles while caregiving. Hands-on health providing, care manager, friend, companion, surrogate, decision maker, and really advocate. You know, many studies have looked at the role of women and family caregiving. Although not all have addressed gender issues in caregiving specifically, the results are still it's generalized to women because they are the majority of informal care providers in this country. So in a way, you're right what you were saying, but the gender, because it's so it's really focused on women, so it is kind of important to recognize that. Caregiving poses greater financial challenges for many women workers, due mostly to loss of wages from reduced work hours, time out of the workforce, family leave, or early retirement. You know, women are more often caring for 2 or more adults, like 27% versus 20% for men caregivers. A greater percentage of caregivers report caring for a man, 39% in 2015, and now it's up to 35%. 41% of caregivers who have been providing care for 5 years or longer more often report caring for a man. 43% of caregivers of baby boomers are caring for a man. That's an increase over 2015. It was then at 33%. So studies find that men respond to caregiving responsibilities in a fundamentally different way. Women tend to stay at home to provide time-consuming care to one or more ill or disabled friend or family member, while men respond to loved ones' need for support by delaying retirement, in part to shoulder the financial burden associated with long-term care. The impact of women intensified caregiving can be really very, very, very great. So let's look at that. 1 in 5 female caregivers aged 18 to 39 said that the stress was nearly always present in their lives. Nearly twice as many as those who were not caregivers and for male caregivers. So that's a lot that women are caregivers that are going through. The negative impact on caregivers' relationship and the social networks due to their reduced ability to participate in activities outside their caregiving role can lead to caregivers experiencing social isolation, which in turn can impact on their psychological well-being. Studies have demonstrated that women are more vulnerable than men to the effect of reduced social support. The physical impact of caregiving can lead to long-term needs for female caregivers. For example, a national survey found that 21% of female caregivers had mammograms less often. So what they're actually telling us is that women caregivers don't really take good care of themselves. For example, 25% of women caregivers have health problems as a result of their caregiving activities. One of them is coronary heart disease, and it's called CHD, is one of the physical risk factor of caregiving. Women who spend 9 or more hours a week caring for an ill or disabled spouse increases their CHD risk. Other health effects, including elevated blood pressure and increased risk of developing hypertension, lower perceived health status, poorer immune function, slower wound healing, and an increased risk of mortality. That's a lot that women are going through. Frequently, support services can make a real difference in the day-to-day lives of caregivers. Research has shown, for example, that counseling and support groups in combination with respite and other services has positive direct effects on health behavior practices for women caregivers. In fact, women are more than twice as likely as men to say that they would benefit from talking to someone about their caregiving experience. Further, some studies have shown that actual links to services that offer information, only programs are more beneficial to caregivers, such as the WellMed Charitable Foundation. The teleconnection that you're on is a great example of this. What participants can share their experience and learn from one another and from other caregivers. So basically what they're saying is that as healthcare workers, we have to be very aware of the difficulties that a lot of women caregivers go through, and that support, especially support groups or counseling, is very beneficial.
I'm looking at our participant list, or just the names, and it does seem actually like the majority of our participants today are women. I'm curious to hear from those participating today if any of this resonates with you.
We have someone who's just on the phone and her area code is 956 who would like to talk to us. Please go ahead. Area code 956-775. Okay. I'm going to put you back on. Yeah, well, there you go. Okay. All right. Anybody, come on. Let's hear from you.
Hello.
Okay.
Hello.
Hi. This is the 956.
Yay.
From the 956 area. Yes, it does resonate with me because I was I've been taking care of my father over 25 years. And recently, like last year, I became he's a veteran, his caregiver. And I was working at the same time, but I was taking a lot of time off from work, and I ran out of leave. And then they started docking my pay, about half of my pay. And I'm a teacher. So what I ended up doing when he went in for surgery, in January, and in May, he started declining. So I decided, because I'm his only daughter here, I'm in Laredo, Texas, and I was all he had, right? So my husband is a veteran. He helped me too sometimes. He worked. So anyway, I had to quit. I resigned from my position, and that's a big chunk of salary, So I was just, living on the stipend, which it was fine, and I don't care because it was my dad always came first. But what happened afterwards was something else. My sister from Colorado came, and when I went to see my dad for 3 days, it was so stressful. She came, and in those 3 days that I went to see my mom, I asked permission from my coordinator. I came back, she was already on a plane with my father to Colorado. She came and she left. Now I'm without a job. And I am, certified through the National Caregivers, but it is very stressful. Now, exactly what you said is what I'm going through at the moment. Now I'm having to reapply for positions because he's still in Colorado, although she did tell the investigator that he was going for 3 weeks back in October. And he ended up in the emergency room because he has COPD. He has heart disease. He has diabetes, you name it. And as soon as they landed in Colorado, of course, the elevation is a lot higher. She lives up in the mountain. That's even higher. So he ended up in the hospital in ICU as soon as they landed. So that's another stressor for me. when you set up everything, he had his home health and everything, and everyone saw the difference. It was difficult, but it's true. Now I'm left in the dark. We're not talking because of obvious reasons. And it's sad, it's stressful.
It is very
So,
stressful.
yeah.
And I just
Yeah.
want to, I thank you so much for sharing and validating what I was talking about, the research. And I'm sorry, all the things that you're going through. And maybe later
Thank
on,
you.
you'll be able to connect with someone. I think you do need to speak to someone. And at the end, Evelyn will tell you how to go about doing that through the WellMed Charitable Foundation.
Oh,
Thank
good.
you.
Thank you.
Thank you. Elliot,
Yeah.
did you want to take the chat from Seema, or do you want me to read it?
Seema had shared that her sister is a caregiver for both parents and back home. And Seema feels bad because her sister has 2 young kids and being taken care of by everyone all by herself. It is a lot of stress. And then she added lots of stress and challenges since third world countries don't have resources like we have here. So I guess, your family is elsewhere. And I am so sorry to hear of all the challenges that our previous participant just shared with us, but this is why we're here, and this is why we do what we do. And I'm glad that you're participating and hope that you're accessing the resources that you need to help support what you're going through. I'm also going to share some information about tips to support male caregivers, because we have a largely female audience today, which is wonderful. But many people have questions about how to help male caregivers. And while the role of women as caregivers may have been true for a lot of our history, gender roles are certainly changing and shifting and continuing to do so. So I think that our continued association with caregiving and one specific gender can sometimes do more harm than good. Especially if, for example, you are a child and you're a male and you don't have a sibling and you need to wind up then becoming a caregiver. We need to make sure that people as a whole are caring toward one another. And I think this is so true. We saw this during the pandemic, certainly. Men had been significant providers of care work and frontline work, both within their careers and also for their families as well. But peer support for male caregivers is really so critical. And it's so critical also because they're less likely to seek it out and more likely to need it, and less likely to talk about their feelings and frustrations. Because again, women are socialized to talk about their feelings, whereas men are not quite often. So it is very important, just as we do for all caregivers, to affirm the role of male caregivers, to encourage them to seek out support and to help direct them to those resources in your community. Again, 211 is a great way to help find out what might be available in your community. There are also a lot of online male caregiver support groups, because a lot of men prefer the anonymity of an online format, which is something that we saw with the caregiver teleconnection early on, when we used to do this only by phone, and we had a lot of male participants, more so than most caregiver support programs. So there is a lot of documentation that shows that male caregivers are reluctant to access help. However, there is a great strategy that we recommend to healthcare workers to get around this. If men feel that their accessing of help will benefit the person for whom they are providing care, they are likely more willing to accept that help. So try to consider that. For example, men more often ask for help if it was for their spouses rather than their own needs. So it's an important thing to consider if you find that a male caregiver might be reluctant to receive help. Try to reinforce that it will benefit the care recipient. And I was just curious if anyone had any comments or questions about that.
Okay, folks, press *6 if you're on the phone. If you're on Zoom, you feel free to unmute yourself or put your hand up or use the chat room. We appreciate all of those. Pick up all of those.
Or if something comes up as we continue with our program, feel free to type into the chat box.
Okay, so shall we move on?
Yeah, we're switching gears a little bit.
Okay, so we're going to talk about the LGBT caregivers, but first let's discuss what those letters stand for. So the current acronym is actually LGBTQIA+, lesbian, gay, bisexual, transgender, queer and or questioning, intersex, asexual and or allies. But for our discussion today, I'm going to be using the shorter term of LGBT. Okay, I hope that everybody agrees with that. You know, informal unpaid caregivers of chronically ill adults is far more common among the LGBT individuals than non-LGBT adults. And stronger support system for this community caregivers are needed, particularly for those who are giving care to a friend and not to a partner or a biological family member. LGBT adults become caregivers at a slightly higher rate than their non-LGBT peers. A recent study of LGBT baby boomers found that a growing number of aging adults expect to be treated with respect and dignity at the end of their life. In spite of this, 1 in 5 of the LGBT adults surveyed cited fear of double discrimination for being older and LGBT as a significant concern about aging. These fears are particularly important to seniors moving into nursing homes or residential care facilities, which we'll speak about more later in our program. So it's so important for healthcare workers to recognize that there is this fear among the older generation of LGBT. So many LGBT people form strong, what we call in quotation, families of choice, in addition to their families of origins as a way of coping with possible or actual rejection by parents, siblings, and other relatives for being open about their sexual orientation or gender identity. Even as attitudes have changed and LGBT people have become more visible and accepted, families of choice still provide valuable networks of emotional and social support. Nearly 2/3 of LGBT older adults say they consider their friends to be chosen family. Being a member of both a chosen family and a family of origin creates a situation where an LGBT person may become a primary caregiver for a spouse, domestic partner, or legal spouse, a close friend who is also LGBT, or an aging parent or other relatives, sometimes all at once. In the community at large, it is most common for informal caregivers such as a spouse and an adult children to provide the majority of care to older adults in the United States. In the LGBT community, with older adults twice as likely to be single and living alone, and 3 to 4 times less likely to have children, a family of choice is dependent upon to provide support and care. LGBT adults are less likely to have children, who are the main source of family caregiving. As well, LGBT caregivers are younger, less likely to be married, more racially and ethnically diverse, and more likely to be of low socioeconomic status than non-LGBT caregivers. Research has already shown that majority of those lower socioeconomic status are less likely to access and utilize resources and community support. So that's really important for us healthcare workers to really keep in mind. So the approach to sexual orientation and gender identity and mental health care often groups together anyone who's LGBT community. When these communities are considered at all, this method can be problematic as each sub-community faces unique challenges, rates of mental illness and experience. The LGBT community encompasses a wide range of individuals with separate and overlapping challenges regarding their mental health. Other identifying factors, including race and economic status, can affect the quality of care they receive or their ability to access care. So we have to be very concerned about that there still is biases in general in our communities, but there still are biases in the healthcare providing community as well. Additionally, members of this community may face harassment or a lack of cultural competency from potential providers, okay? These experiences can lead to a fear of disclosing sexual orientation or gender identity due to potentially discrimination or providing biases. We have a whole session on this topic that we go into more details, but I really think it's very, very important to know that this is how a lot of these individuals feel, and they are scared.
It's everything you say rings true from my own personal experience with healthcare, but I think it's very important that we recognize that older LGBT community members have very unique experiences with healthcare. In fact, it was not until 1973 that the APA removed the diagnosis of homosexuality from the Diagnostic and Statistical Manual of Mental Health Disorders. So imagine if you were born in the 50s, you were in your 20s, perhaps your early 20s, when homosexuality was still considered a mental health disorder. So as such, older LGBT adults are 5 times less likely to seek out social services and medical care than the general public. And there are good reasons for it. This is something, as Lucy, as you said, that we talk a lot about in a dedicated series on issues affecting LGBT caregivers, and there are many, but also issues affecting LGBT patients. They're very different. For example, when I go for my annual physical, despite the fact that I have been married for 18 years, I'm always asked to get an HIV test, which is not the experience of other people who even see my same primary care physician. So there are unique experiences that definitely link to bias and other things that we've talked about. But there is also something called internalized homonegativity. And that's where you take all of the bad feelings that we live with and you sort of internalize it. And that is unfortunately something that a lot of older LGBT adults deal with. And it's something not much talked about, but it is the consequence of trauma that stems from personal experience and also from healthcare experiences. And that's why it's so important for healthcare workers to be sensitive, to think about what the experiences are of patients. And that really brings us to cultural competence, which is a term that you may or may not have heard. It's not a new concept. It was first used in 1989, but many organizations have embraced this term, which really means that there are a set of behaviors, attitudes, and policies that come together in a workplace or a system and among the professionals that work there to effectively work in cross-cultural situations. So what does that mean in layman's terms? It means that the organization values diversity, has the capacity for cultural self-assessment. You might want to think about where it is that you've worked, for example, and think about when the last time might have been that there was a diversity survey, or perhaps an event at work where people's cultures were made to feel important, or if someone was doing like a cultural potluck. That used to be something at my place of work that we would do quite often. It's also important to be conscious of the dynamics at play when cultures interact. That was one of the really nice things about those potlucks, is that we would often walk away recognizing that we're more alike than we are dissimilar. It's important too to have some level of adaptations for service delivery that show an understanding of cultural diversity. So for example, if you know that a patient celebrates the Sabbath, for example, that's something to be mindful of and also to factor in for care planning. So these are elements that should certainly be reflected in attitude structures and policies of organizations that serve healthcare. But like I said, take a moment and think about if this feels reflective of where it is that you work. And why does it matter?
And why does it matter? For sure. I think that as healthcare workers, we don't have the luxury to we all have our biases, or culturally we make all kinds of assumptions about people. But I think it's very important to keep that in mind. There is a strong evidence that cultural competency training for healthcare professionals provides knowledge, understanding, and skills for treating patients from different cultures, different languages, socioeconomic diverse backgrounds. Additional evidence is needed to determine effects on a patient care and health outcomes. There is a reported increased patient satisfaction and improved health outcome with clinically significant improvements. So I guess what they're talking about is to be sensitive, not to judge people, and to treat people with respect. We know this is essentially true when it comes to long-term care and long-term care planning. And sometimes, unfortunately, placement in long-term care sometimes comes down to availability of bed and having the means to pay for it. We've been facilitating sessions for the LGBT seniors and caregivers on how to find culturally competent long-term care and the importance of finding a facility in which people feel at home with regard to their culture or religion is very, very important. Not only it takes into context many things. For example, food, music, faith-based and culturally focused community groups and agencies can be very helpful in identifying culturally sensitive long-term care support in a variety of communities. Familiar things like language, food, celebration around tradition or holidays are all linked to patient satisfaction and improved health outcomes, which impact both the patient and the caregivers supporting them. Training like this is it's important to sensitize healthcare workers to ways in which we can show our patients and their caregivers that we appreciate who they are and where they're coming from. There are also many other research for tools and interactive games that you can play with challenges to enhance cultural sensitivity and understanding. So I just want to kind of open this up a little bit to see, have you personally experienced biases about your own culture or sexuality? I can share with you that I have, not about my race, but more about my religion. People assuming that I'm of one faith and then saying a joke about another faith and me feeling kind of, oh my God, they don't even realize that they just made a joke about me and my religion and what it does. So you could just very well imagine what it would be like if we're not sensitive to not only definitely to different cultures and just being aware. And by being aware, Elliot said that before, being aware means that we educate ourselves. If we meet a patient or a client from a different culture, I want to know about it. I'm interested to know what is it their culture all about? Because that gives me a better understanding of how to address that person. What are their values? What are their needs? So I just kind of wanted to open that up a little bit. and to share. So let's have some conversation.
Yes, please, if you're on the phone, press *6, and I can see that you've done that. And I'll call you by your area code. If you are on Zoom, just unmute yourself, go on chat, put your hand up. The input we get from our participants makes on a podcast so much richer. I just want to tell you. So we really encourage your input. There's nothing you can say that we don't want to hear. And Lucy, I'd just like to say, I'm so happy you used the word assumptions, because I think that's really the basis for disrespect, is that when you assume that you know who somebody is and what they need and what they want and how to get it to them, that you're not asking them, you're not letting them be your partner in care. And it makes such a difference when they feel empowered. And that's really so much of what cultural sensitivity is.
Yeah, for sure. For example,
Very well said.
go ahead, Elliot, go ahead.
Please go
No,
ahead.
I was just thinking, assumptions. For example, if you meet an elderly patient, a gentleman, or even a woman, and you might not even realize, you'll say, well, do you have, you might say to the gentleman, well, do you have a wife? The person might be gay, so you have to just really recognize that and be conscious about the language that we use also when addressing and asking questions. And I appreciated, Elliot, when you said about you going to your general practitioner and asking you to take that kind of a test. That's really an assumption, isn't it?
Well, it used to be something that was based out of clinical guidelines, and there was a time when gay men were at higher risk, certainly. But that is based upon behavior, multiple factors, and we're looking at things differently now. But if a provider received their training some decades ago, then that might influence how they then interact with their patients. And
Lucy and
okay.
Elliot, oh, sorry.
Yes, sorry, go ahead, Evelyn.
Can you address ageism as part of being culturally sensitive?
Yes, that's very good. Yes.
Certainly.
It's huge.
I think, to your point, within certain cultures, for example, if we go back to gender and we'll look at very basic gender, there is, I think, a feeling that women have about aging, and that they need to look a certain way. I think more and more men are feeling that same way now. But I think certainly, for example, we've talked about, the LGBT community. As a man who is part of that community, who is aging, there is certainly, it is a very youth-focused culture. And I think that as we age, we sometimes feel invisible, and we sometimes feel like we're not sure of where our place is. And I do think that sometimes is true for a number of different cultures. And in that sense, then there is ageism that is very cultural, and that is steeped in those traditions. And on the flip side of that, you have cultures where aging is revered, which is something I'd like to see more of in our culture, quite frankly.
I can't tell you how many people have said to me something like, well, you can't do that because you're too old.
That's
and you know what? I can do it.
Sure.
Well, aging is not an illness. It is not
Right.
a disease,
Right.
and that's why, just in the same way that, being gay does not mean that you're at greater risk for HIV. It's much the same.
It's an assumption.
Yeah, and we need to think of things quite differently. Next month, Lucy and I will be hosting what we call a series of emotions. And we've begun doing work on that series, talking about some of the common emotions that caregivers experience. But in doing some new research, something that that I'm bringing up now because it speaks to this point is that we assume that everyone grieves in a similar way, or that our experiences with grief are somewhat similar. But in fact, different cultures have very different experience with grief. And what a major study just found is that Black Americans have a much more difficult time processing grief than other community groups because there is so much grief in our environment. We're constantly seeing people who have been murdered by police and bad things on the news. And so grief of any kind, the loss of any person of any age, signals other things: loss of hope, trauma, a greater propensity for sadness and depression, and also less likelihood to seek out help to get through that experience and to help process that grief. So these are all really important examples of how our culture really does impact our access to healthcare, our willingness to access healthcare, but also our experiences with mental and physical health as well.
Well put, Elliot. I just want to go back to what Evelyn was saying. When I did my master's research, I did it exactly on healthcare workers and their attitudes towards aging. And what I found, there were nurses, social workers, doctors, physiotherapists. Ageism really exists in our society, even then, and that was in the 90s. It still exists today. I think it's really important to identify that. If you see an elderly person maybe on the stretcher in an emergency, and they're kind of raising their hand or they're trying to reach out to you, many times people will just assume, you know what? They may have dementia. So assumption is there. We have to be very, very, very conscious of that, especially when we're working with seniors. And maybe that person is having a bit of a situation. They might have a urinary tract infection and they appear to be having some sort of memory loss, but it's a medical thing. So having said that, I know that there are amazing healthcare workers in the healthcare system, dedicated people that are there. And I'm sure the ones who are taking up our course are dedicated, because otherwise you wouldn't be here listening to diversity. So I thank you for that. So I just wanted to kind of generalize and not sort of make a point.
Absolutely. And before we wrap up our program for today, I did want to open it back up for any comments or any questions that anyone has. We will also be sharing a number of different resources.
We'll send those out with the post-session questionnaire. I'll tell you about that in a minute. But if you are on the phone, please press *6 to unmute your phone, and I can see that it's been unmuted. Or you can unmute yourself on Zoom. Or go to the chat room, put your hand up. We would love to hear from you. Questions, comments.
One of the last things that I just wanted to quickly mention is the fact that a lot of health systems and hospitals are still very much rooted in faith, and even the names of institutions. Like my closest hospital is called Holy Cross. So it's important that we're just mindful of these things as well, because sometimes just that can be a barrier for people too. Phyllis, please go ahead.
Phyllis,
Hi.
yes.
Yeah, Phyllis Sargent. I am a caregiver for my mom. I've just listened to the whole meeting. I haven't had much to say. I was just listening, and I'm just letting you know that I have enjoyed all the information that I've gathered today. And thank you all so much.
Oh, thank you.
Thank you for being with us. We really appreciate that.
Sure, you're welcome.
Well, I have one more example of ageism, Lucy. And I think I've mentioned this one before, but when I tell people, I used to work in nursing homes as a consultant. When I would tell people, that I went to nursing homes on the weekend, they would always go, "Oh, that sounds terrible." And I go like, "Are you kidding me?" I walk in the front door in the lobby, people are sitting in their wheelchairs looking out, and they all start clapping. I go, "Oh, she's here." They didn't know who I was. It's just they had a visitor. So
Yeah,
it was a great thing.
Ageism exists because we have a fear of aging, but we shouldn't have a fear of aging. If
Right.
we don't age, we should fear it, because that's what we should all want, to age and live full lives. But unfortunately, our society in many ways is very youth oriented and just having no wrinkles and just, I having no white hair. We get caught up in all that, but we have to kind of step back and say, what's the alternative? Thank God I'm aging. That's
And
what I.
there have been some surveys lately, people who are 60, 70, 80, 90 years old who have said, this is the best time of my life. I have time to do what I want. There's no pressure. There's no stress. This is the best. These are the golden years. Now, I know caregivers have a little different experience, but for those who are not caregivers or who, like me, are finished with my caregiving jobs in my family, my grandkids are growing up and my parents are gone. It can be a pleasure. It can be a real pleasure.
I was watching the news and Jane Fonda was being interviewed. I don't know if somebody saw, it was just 2 days ago, and she's like 80 something, 85, I think. Looked amazing. Okay, besides that, never mind that. But she said, this is the best time of my life.
Yeah, she just launched a line of workout clothes with H&M, which is amazing. But actually talking about the importance of being mobile as you get older, because you need muscle strength to get up and down from a chair and to have
be
balance.
Upright. Yes.
Exactly. All important things. And as I mentioned, we have our resources up. The number for the WellMed Charitable Foundation is listed up at the top, and I would encourage our participants from earlier in today's program to please reach out. There are also additional resources here for cultural competence, and especially those focused on the LGBT community, because right now there is a lot of concern about medical care and laws and what you can and cannot say. And so this is an area of some attention right now. So certainly take advantage of those resources. And I really want to thank our participants today in the comments as well.
Right. And just as a wrap up, I want you all to know you'll get that post-session questionnaire in a couple of days. It'll come with the resources, with the slides. And if you're not registered, you won't get it. So please call the number at the top of your screen, 866-390-6491, and get registered. And you know what else you'll get? Oh, you hit the jackpot. You'll get that monthly calendar. And boy, next month we have 13 different presentations, varied, wonderful, all to be done by experts and needing your input and comments. So please join us. We will really like that. Thank you all for being here. Elliot and Lucy, what can I say? You guys are always amazing. Both your slides as well as your questions and your real respect for the participants, right, and how they feel and what they have to offer us. And I also want to thank the WellMed Charitable Foundation for their generous support of the Caregiver Teleconnection, Stress Busters program, SOS clinics, all of the great things that they do. And with that, I'm going to stop the recording and thank all of you so much for being with us today.
Thank you so much.